Hello and welcome to Recalibrating with me, Sharee Johnson, where you'll hear healthcare professionals and others sharing their stories of recalibrating life when the unexpected happened. As a psychologist and a coach, I've been listening deeply to people's stories for 35 years, and I've come to believe two things about people. The first is having witnessed so many incredible stories of hope, adaptability, and human capacity, I truly believe that we are all capable of so much more than we really think we are. In times of challenge, humans have demonstrated that over and over again. Here on the Recalibrating podcast, you'll get to hear amazing stories of healthcare professionals and others pivoting, overcoming, and recalibrating their lives. The second thing that the research and my experiences as a psychologist have shown me is that humans need each other. We need people. When we have support around us, when we tell each other our stories, when we connect through the reality of living our lives, we do so much better than when we pull back and hide what's really going on for us. Together on this podcast, we're going to unearth and amplify what helps us as humans individually and collectively to recalibrate in ways that help us change, grow, adapt, even surprise ourselves when life throws us a curveball. This podcast offers you the chance to be inspired and encouraged to meet the unexpected in your life with grace, skills, and a belief in your own human capacity. Life is full of opportunities to recalibrate with agency, the right mindset, the right resources, and the right community. Dr. Kieran Allen is a doctor completing specialist training in psychiatry. He blends his unique experience as a clinician and a patient with his own lived experience. Employing storytelling as a tool to share his experiences, Kieran openly explores the challenges of navigating medical practice whilst living with a mental illness. Kieran challenges the fallacy of the doctor-patient binary. He illuminates the value of incorporating our whole selves to positively influence systems of care. Dr. Allen shares his personal journey to highlight the reality that mental illness can affect anyone, including doctors. He advocates that these experiences deepen empathy, insight, and connection to ourselves and our patients. He is particularly interested in reframing narratives around burnout, promoting early help seeking, and creating cultures where vulnerability has value. And we talk a lot about that in our conversation today. Dr. Allen has held leadership and advisory roles across higher education, professional associations, and in the not-for-profit sector. He has served as a representative in diverse governance roles, contributing to conversations about training, well-being, and professional culture. His advocacy work is explored through his writing, podcast appearances, and public speaking, where he seeks to foster a medical culture that values honesty and challenges an idealized linear view of recovery, promoting diverse paths that doctors can take through healing. Welcome to Recalibrating with Sharee Johnson, Kieran. I think we're going to have a really heart-provoking and thought-provoking conversation. It's lovely to see you.
Hi, Sharee. I'm certainly hoping so. It's good to see you again.
Let's start with your working life now. What's work look like for Dr. Kieran Allen in 2026?
The work is very exciting for me this year. I've come back to full-time work this year after a period of doing part-time, and really enjoying my job in child and adolescent psychiatry, this rotation. It's something quite different, I think, from the rest of what I've been doing so far. It sits at this lovely nexus between treating children and treating their parents at the same time, and watching how the family operates and trying to support the whole system, which is something we do across psychiatry, but I think it's to the pinnacle when kids are involved. So I tend to balance the clinical work with some things outside. I enjoy doing writing, doing advocacy work, and I sit on a couple of different advisory bodies and a governing council. I try to spread the load a little bit in terms of what I'm doing.
Mm-hmm. And how far along into your psychiatry training are you?
Again, I'm in a somewhat unique position. I have to count sometimes where
Yes.
I'm up to, given that I've had time away and I've had part-time. I think I'm at the end of my third year at this point, and it's 5 years for the training. So I'm finishing my mandatory rotations with this child and adolescent one, and then I'll move into the wide world of stage three, which is very much open to however you want to do it, which is quite exciting.
Yeah, very exciting. Congratulations on making it
Thank
through
you.
all these hurdles. So,
Thank you.
what about the backstory, Kieran? Can you tell us a little bit more about your life? Things, seminal events, things that happened to bring you to this stage. Maybe a little bit of your family background and the work, the steps through medical school and to this point now.
Yeah, so my family were very supportive of my moving into medicine. They were very excited for me to choose that. I don't think there was a pressure as such to do so, but they were certainly very excited when I got in. I think getting into medicine was a unique experience in terms of, when we're in, I went straight from my high school to medicine and went from being the top of the academic pile to very much the low middle in medical school. That was a big shift and a big adjustment in terms of how I saw myself. And I found the early parts of medical school to be quite enjoyable. They were preclinical and very academic, and it was quite a focus on knowledge and knowledge acquisition. And then moving into the clinical years, I found that much more challenging because the challenges with some of the people who were teaching and trying to, I think, in their own way, support learning, conflicted with my personality style, probably, and probably from the outside often stretch into more of a bullying type approach, or at least a teaching by humiliation and teaching by calling people out and making others know that they didn't know things.
Mm.
Um, and I don't think I was alone in that experience, but I got through that and moved into. I had my first psychiatry rotation in my fourth year, and I did not enjoy it. I did not like it at all. Um, and I don't know if that says more about how it was run or more about what I was expecting going into it. But I thought, I'm going to try this again. I'm going to give it a once over and see if it was indeed that. So I did it again in my final year as an elective, and in that case, I did really enjoy it. And went into internship and did another psychiatry rotation then. And I found internship to be kind of a baptism by fire in a lot of ways. There was certainly an expectation that I had put on myself that now that I was a doctor, I had to know everything, do everything, take care of everyone, rescue everyone. All of that came to a head at that point. And I think it took a number of years for me to look back and say, it probably wasn't accurate. I probably didn't need to feel that way, but not knowing in that setting, I certainly felt that. And I went from internship straight into a year as a resident in psychiatry um, and did a bit of inpatient work and a bit of community work. And I thought, this is something that I want to do. This really aligns with my interests in how people think, how they process things. I liked the time in a way that you have to think about people's approach to things, how they struggle with illness, how they struggle within their families at times, and the kind of reflective practice that I don't know exists in a lot of specialties. That certainly was present. But at the same time, in certain rotations, it was very, very busy, and that ideal practice wasn't always able to be achieved. But I had times where I needed time away for being unwell with what at the time was thought to be depression and thought to be a quite a recurrent depression. And that started in medical school. I took at least at least 2 years off and a research year, which really pushed back my training. And it continued into my clinical years as a doctor. And it was very annoying. It very much got in the way of what I was wanting to do. and it just would not go away. I kept falling into these holes of depression and really struggling to get out of them. I was in hospital many times because it was so significant and the risk was so high, um, and could not work out why uh, this pattern just kept repeating itself. And there were times where, I was doing things that were just out of character for me and didn't make sense and seemed to be getting worse over time. And one of my psychiatrists finally said, "No, I think this is bipolar." Um, and a lot of things made sense once we looked at things through that lens. But it was tricky to see because predominantly for me it was depressive, and even when the manic symptoms were there, they were more mixed, and they were covered up by a lot of depressive symptoms. So it was tricky for anyone to see, I think. But even with that, it was still very difficult to get on top of. I had quite a treatment resistant form. I was having multiple episodes a year, and it was meaning that I was having to take a lot of time away from work and training. Um, and that that stretched on for a long time, for a number of years, and I really lost um, a lot of yeah, I think time's the right word. I lost a lot of time that felt, looking back, was really wasted. I just can't get that time back, and it's not just the fact that the depression was awful, um, and feeling like ending my life is the only option.
Mm.
That's horrible enough going through, but then to reflect back and say, well, there are years there that are gone, that were effectively feel like they've been wasted, and to not have that time has been very hard. But to come through all of that and process um, what has been a very complicated illness, and get to a place where I've been stable now for over 18 months and been able to get back to full-time work, um, has been something I didn't know would happen, and very that comes with a real sense of relief and joy.
Mm. I imagine you've had the full palette of emotions through all of that time, Kieran. There
Yeah,
must
I think,
be times where you really wondered if it was worth carrying on with medicine.
I mean, that goes back to medical school. I think I had my first episode in high school, but the first real bad episode was in medical school, and that was the one of the key things.
Mm.
Like I don't think I'm cut out to be a doctor. I don't think that any when you fall into such a heavy depression, it nothing nothing makes sense the way you think it will. Like there's this real it's hard for people who have not experienced it to genuinely understand it, I think, because the people equate depression with sadness as a way of understanding it. It's like, wow, you must have been really sad. It's
Mm.
like, yeah, I was, but that's not the whole picture. Like the way you think changes. You
Mm.
can't reason. You can't understand normal things in a normal way. Every little thing that happens in your life, you're looking at it through a lens that just makes it not make sense the way it should. And therefore, coming to what from the outside seems like, why are you thinking that way? Why isn't this making you happy? Why are you thinking killing yourself is a good idea? It's hard to understand. And I think,
Mm.
funnily enough, I actually think people have a better understanding of the suicidal part than they do about the actual suffering, um, because they can see that that's sort of an escape, and things are so bad that that's the only option. People can understand that, but to say to them like day to day, I have constant thoughts of just hating myself and hating my life, and it's just unrelenting. Um, that's horrible, and it's exhausting too. And to have that go all the way back to medical school and conflict with your identity as a professional, as a doctor, it fuels it, and it gets you stuck in a loop. I think sometimes where even when you think you're getting out of it, that's not always easy because of the fact that the prototypical identity of a doctor is the strong figure, the figure that makes all the right calls in hard decisions. And that's to not be meeting that is difficult.
Incredibly difficult. I think that you're really touching on something for the people around the person with the depression as well, that they're using a different thinking frame. They're thinking through decisions and problems in a different way, and that trying to understand what's happened to your thinking capacity as the person who's experiencing depression is confusing.
It is, and I think it goes one step further from that though. I think, the people around you, people who are, I don't like this term, but carers, um, people who are in the carer role, and they're often put there by the clinical team when people have a psychiatric illness. They're not supported for one, but even if they were, trying to explain to someone that this experience that this person's going through is not really them, it doesn't hit home for that person. They look the same. They they talk the same, even if it's slower and a bit more monotonous. It's still them doing it. And so you can't separate that in these people's minds. And I think that really comes to the fore with mania. Like when I'm in that state and I'm talking a million miles an hour and I'm saying, grand plans and stupid decisions, that sure, in my mind, in my psychiatrist's mind, is a state. But in the people around me's mind, no, 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 that's an experience of this person, and you can't separate it from the person, and your reaction to it can't be separated either.
Mm.
And so it's, if I'm then talking to someone when they're not in that state, to that person, they're like, well, that was horrible to go through. But to the person who's in that carer role, it's like, I went through all of that, and you are the same person, and I can't disconnect from that. That's really
Mm.
tricky.
Very tricky. What was useful? What was supportive? What was helpful?
I think that's a really hard question to answer because I think when when I am so sick that I'm at the point of being in hospital, say, I don't know that at that point I'm able to identify anything that can help. And so really, I become very much needing those around me, clinically or family or friends, whoever, to guide those decisions.
Mm.
And that can be really helpful, but it can also cause problems in the sense of things being done that have the best of intent, but don't necessarily end up with the result that me, as the person, would have wanted.
Mm.
Um, and the extreme of that, obviously, is when compulsory treatment's used. And as far as I can remember, that I don't think that's happened with me, but it's been close to that. It's been sort of, all right, this is the plan, and if you don't go along with it, then we're going to do it anyway. Um, but and I think that has a spot. That certainly has a role when people are extremely unwell. But I think most of the things that help have not been around when I've been actually sick. It's been outside of that. It's been the support of work to have flexible working arrangements when I'm coming back from being unwell, or my family having the ability to work out how involved to be without being over involved. And that varies between people, it varies between how sick you are, and that's a hard thing to work out. But I think that the two most important things are the support of my wife has been critical. And I know not everybody is in the position to rely on that, but I have been fortunate enough where she has just been fantastic throughout my journey, but it's been very hard on her too. Um, and the other support is my professional team, my clinical team, and being able to access them routinely when I'm well, so that when I'm not well, they're there.
Mm.
So having, even if it's infrequent appointments, like every few months or every couple of months with my psychiatrist, or acknowledging the value of, and it doesn't have to be therapy like I'm doing, like what your role is for a lot of people, which isn't, it's not a therapy role, it's a coaching role, but it's having that support as an ongoing thing. It normalizes the fact that we can get value from that even when we're not unwell. And being unwell, then it's easier to access. You've got an established relationship, you've got someone you can turn to. So I found that really helpful.
I think you're pointing to something very important, which is this deep trust that you have a group of people. It doesn't matter if we look at the Harvard happiness study or, it doesn't really matter which study we look at. It's all pointing to having people that we can rely on, that we have some level of intimacy with. We don't need lots of them, but we probably do need more than one each. And I think it might have even been you who said it. I heard someone speak years ago who said, you need your 3 a.m. friend that you can call. Did you say that? Is that a thing you would
I don't
do?
remember, but that sounds like something interesting.
A lot of people, especially in coaching, we talk about this idea of the hero's journey, that we go through a struggle, that we're sort of in the dark, we can't find our way, and that we need a guide on the side, or we need to find somebody to help us. And it's very often about building skills and competence. It can be also about relationships and autonomy, but it's really principally, I think, about skills. And I know when we were talking yesterday, you raised some questions about this idea of the hero's journey. Can you share a little bit about your reflections on that?
Yeah, I think when we talk about something like the hero's journey, it's a nice way of framing what we would like the journey to be. I think a, it's reasonable and it's a good way to hope for. And I think what you've just mentioned, focusing on the development of skills and things like that, is a really useful way of using it. I don't think a lot of people do use it that way, though. I
Mm,
think a lot of people frame it in a way where it's um, an individual is exposed to stress, becomes unwell, and falls into, a challenge, a depression, whatever it is, burnout, and seeks to climb back up the hill to get back to where they were in recovery. Um, and I don't know if it's as explicit as that, but I think it's incorporated a lot into how we subconsciously view mental illness, particularly in the workplace.
mm,
There's a recognition organisationally across most health services, I think now, that burnout is a major problem, and it's not, and it's probably getting worse. From my experience, quite good at identifying some of the reasons for that, but not as good at identifying how to fix those reasons. And there are good reasons for that. They're complicated reasons that are systemic and difficult. The thing that I think upsets most of my colleagues when I talk about either burnout or the response to it and that journey we seem to be pushed towards is that the focus on trying to acquire skills and trying to develop resilience is not a bad thing. They are good things to put in place, but they are peddled sometimes as the only ingredients. And they're the focus on the workplace promoting those comes across as hollow because the actual underlying systemic causes are not being addressed. Or if they are, they're not having the effect that the organization are wanting them to. On the other end, though, it also idealizes what can be seen as a state of recovery, as, rather than viewing that journey as the valuable thing, the there's almost this sequestration of people in this little hole that we don't talk to them. We don't, we might touch base every now and then, but they sort of sit there until they get better. And once they get better, we celebrate that. Wow, you must have been through something really hard. Well done for getting back. But there's this subtle pressure to stay in that role and to not fall down again. And you've
mm,
got people who are going back into the very same system that caused them to feel that way, probably not even back to where they were when they're coming back. And so
mm,
the likelihood that there will be a relapse is high for a lot of people.
mm,
And that might not happen immediately. People might, get back in. And the workplace might be really supportive in terms of letting them come back part-time for a while and supporting them through that. But you've got a situation where those skills are helpful in terms of coping with stress, in terms of managing workload and advocating for yourself. But a lot of people are not able to easily implement them in a system that still causes the same problems.
mm.
When you're heavily stressed, you revert to a survival mode. And it's impossible in a lot of those settings to use a lot of those skills when you're so distressed. And even at that like baseline of distress, it's hard to do. You're just pushing through and surviving with that little voice going, "You're going to get on well again. This is not going well." You know that that might happen. And it's just constantly telling you that. And there's this shame, I think, around within people who do fall into that and who do sort of fail to adhere to a preferred narrative. And I experienced that myself, getting back early on was very difficult at the very start of my, in my intern year in particular, and starting to do work around advocating for the mental health of doctors. I was lauded for that and given, registrar of the year and, things like that. And then when the shit hits the fan, so to speak, you really see who's supportive and who's not. I mean, it's easy to support someone when they're well and to say, we're championing supporting mental illness and we're not stigmatizing, there's no discrimination, all of that, until the challenge comes. Because once you become difficult, that's when the actual discrimination comes out. And that is particularly bad, I think, for people who don't stick to that hero's journey or that ideal of it anyway.
Or even perhaps people who take too long to get through the hero's journey.
Absolutely.
There's too much complexity for too long. If you have, one incident and you get it together and you get the skills and you come back better, we like that as humans.
Yeah.
We like that simple, kind of straightforward.
Yeah, it's neat.
Neat, yeah, yeah. I think you're really pointing to, I want to go back a little bit to you talking about the connection with your clinical team all the time, not just when the shit's hitting the fan, but just all the time. Generally speaking, I just want to kind of amplify that for a minute and remind us both and anyone who's listening probably that I think there's such power in this. And when you look at workplace well-being, traditionally, organisations, not just in health, have had EAP and sort of crisis response management, and that's been the focus. I think now we have evolved a little bit to thinking about psychosocial well-being at work all of the time. I think we've still got a lot of work to do, but at least we're talking about that language now, and we're talking about, good work is good for well-being. People who have work that helps them feel like they're contributing, that gives meaning to their life, that helps them feel like they're valued, is really great for our mental health as a general statement. Long-term unemployment is better for us, for our mental health, than a toxic work environment or an unsupported work environment. So, I think the research is really clear about that, but we seem to be very slow about activating it. And I think I mentioned to you before that I like the phrase of having some redundancy in the system. So,
yes.
I'm thinking about we want the capacity to have heroes' journeys individually some of the time if it's about skill building and increasing our competence. We also need this systemic response, and it's much more complex because there's more moving parts. Where's your thinking at just now about things that systems can do or things that you've seen leaders do that have made a difference in our systems?
Yeah, it's a good question. I think it ties into what you said before about one of the key problems is when people take too long to get better, because it interrupts those systems. We're caught between so many moving parts in medicine, particularly in the training pipeline, where we've got more doctors graduating than ever. And importantly, we don't have enough doctors, but we haven't seen the same rise in training places. So they've got nowhere to go. And even those who are in training get stuck without the problems of taking time off due to their mental ill health. Trying to find places for rotations we have to do, things like that, makes it really tricky. This is massively compounded in the rural setting where the access to those positions is just often not there. Or if it is, it's very hard to put people in who then need to take time off. It delays everybody. And that's not the fault of the individual, but it often is framed as such. And so when a system is so rigid that it can't tolerate someone taking time off, and it doesn't even have to be mental illness. People get, pregnant with kids. people want to take long service leave. Like to force people into that rigidity and say, no, we can't do this, we can't fit those things in, is a massive structural problem. So when we talk about redundancy, I think part of that is, saying let's get more doctors and get the capacity for people to fill holes when they come up. But it's also a responsibility of the colleges, I think, because when they have rigid training requirements, they they are important. It's important for me, for example, to be doing child and adolescent psychiatry. That's a critical thing to understand, I think. But to have so few physicians to be able to do it and so few supervisors to be able to supervise it, it really makes any of those flexibilities difficult. And it's not just saying, oh, we'll change the structure of the training program. Like, okay, but we still need that experience, even if you make it a bit more flexible. So how do we get the supervisors? Well, you need more consultants. How do we get more consultants? We have to train them. You're stuck in this loop where there's no easy solution to it. And I think trying to break that open and see how do we adjust it? How do we fix it? I don't have the answer to, because I think I worry that no one does.
Mm.
And when that happens, all we do is we go into crisis mode when we're trying to support someone. And there's this phenomena, I think, where um, I think people in sort of middle management, who are often the ones making the decisions around how to support doctors when they do become unwell, um, get stuck in this adherence to policy and practice, and this is how we do it, this is how we have to do it, without almost being scared that whoever's above them is not going to agree if they shift. And there's this protection of that system from within. I
Mm.
don't think that's unique to this. I think we do it in medicine all the time, with like holding people to, no, you have to do this, you have to do this. Um, it's a part of the profession, I think, and it's a part of our risk-averse, compliant nature.
Mm.
But I think we do need to look at all of those factors in terms of what, and to be fair to my own college, they are trying to look at all of this in terms of redoing a curriculum, but that's planned for 4 years from now.
Mm. Mm.
Who knows how the system is going to look in 4 years' time, and then the implementation beyond that. So I don't know how to do it now. There needs to be brighter minds than mine to be able to look at this, but there seems to be a lack of capacity within that system to do so with so many moving parts.
I think you're highlighting this challenge that people often say, well, the doctor wellbeing has to be secondary to the patient's safety. I don't agree with that. I think they need to be equal, because we know that when the doctor is well and the doctor has support and is valued, seen, heard, they do better work. We know that the patients have better health outcomes
Mm.
and they have better health experience. Their experience of being in the health system generally is rated better when they feel like they're connected to the doctor, there's empathy, and the doctor is, if you like, well enough to be present to the patient. So I think this sort of binary, or this dichotomy that people talk about a lot, that well, it's either the patient safety or the doctor's well-being. It doesn't make sense to me, I guess, is the short version. And I think that's part of what you're talking about, that we need protocols and we need these slow-moving processes for training. We need to make sure that doctors have the skills and the competence and the time to develop the skills that they need. And we also need psychological flexibility. We need a way of being able to say, how do we respond to this bottleneck with lack of supervisors so that we can get more doctors on the ground? I also find myself thinking while you're talking about, um, I guess, the territories. I know that's a bit of a provocative word, but can nurse practitioners do some of the work of general practice, for instance? In New Zealand, they do. In Australia, there's much more resistance to that from the GP community. Can other mental health workers somehow support or complement in new ways what psychiatry does? I wonder, if we look at that broader landscape, what kinds of things we might notice. Any reflections there?
I think you've touched on some very complex points. And you're right, there are so many small modifications that people seek to make that face real stiff opposition politically. The college GPs and the nurse practitioners it's a good example, and the opposite where, pharmacist prescribing has come in.
Mm.
Now I would compare that to the College of Psychiatrists had a choice when it came to the management of ADHD, whether they really knuckled down and said, no, this is our territory,
Mm.
or maybe they read the tea leaves here, I don't know, but they chose to engage with the College of GPs and said, how do we do this best? How do we adopt a shared care model that is
Mm.
going to improve access whilst maintaining safety? We will train you how to do this well. We will offer that training to you and let go of, our $1,000 an hour ADHD clinics, and made that decision for a better positive outcome overall. Because what happens is if you don't do that, someone else comes in and does it for you, and that's typically the government. And that is, I think, what has happened a lot with the pharmacist prescribing, for example. The engagement with GPs has been either great or terrible, depending on who you talk to. But the lack of willingness to adopt a model that would be effective has led to the government just saying, well, this is what we're doing. The profession faces that. And I think the College of Psychiatrists made a clever decision in doing what they did. So there's parts of the system that can improve. I even got invited to a panel the other day, which was, should psychiatrists lead from the inside or the outside, or along those lines? And my question to the panel host was, there's a problem with the question because it predicates that psychiatrists are the right leaders. Like, are they? What evidence is that I'm not saying they aren't, but prove to me that they are. Or do we need a different model that, has different input to support the clinical leadership? Who teaches you how to be a manager? It's like they don't. You just learn it on the job and you pick up whatever skills you can. That's not right training. That's not the right way to do that. So it's tricky when you've got these encampments, these entrenched roles that people feel like they have to defend. And it makes it really difficult to shift anything. And there's a lot of rivalry, I think, even within medicine. I think that's most particularly seen when I was doing consultation liaison. There's between the medical teams and the nursing staff, between our team as the CL team and the medical teams, and who owns patients, and it can be a mess sometimes, and there's a lack of collegiality, I think, and it permeates that culture permeates through to the individual who feels that well, they're attacking me, not just they're being nasty to my team or else. Yeah.
Oh, as a newcomer, when I first came into talking to doctors and thinking about these questions, it was really shocking and surprising, all of these things you're describing to me. I think as a member of the community, people have no idea, we don't need to know, so we don't know what the machinations are that are going on to keep the health system alive. And you really made me think about the people in survival mode don't behave like people who are thriving. People
No.
in survival mode are protective, are defensive, are sometimes working to rule because that's how they can manage to show up again tomorrow. And so I think
Yeah.
these are huge challenges. I'm aware that in our conversation we've met a number of kind of recalibration points for you where you've had to recalibrate and rethink and reset. I wonder if we just pause here and if you can notice what skills or what belief systems or what's helped you know that you can recalibrate, or that you need to recalibrate, that some new information has come in that's interrupted, I suppose, your thinking system or your beliefs. What's that process? How can you help our listeners
One
think about that?
one of the things I like about having that ongoing therapeutic relationship in terms of the psychological work has been that it's really helpful for trying to get to those points. Because I don't think for most people it's gradual. I think there's usually a thing that happens and they're like, okay, I was wrong. The way
Mm.
I was looking at this was completely wrong. And I think in the moment when you're unwell, things like utilizing CBT is a good approach. It's very directed, it's very clear what the goals are, but it's also not getting, I think, a lot of the time to the underlying issues.
Mm.
And it shouldn't at that point, probably, because people are not in a state where they're able to do it. So when you're outside of that acute phase, there is the space to start to work on things that might open up those recalibrations. For me, it was through parts work. My psychologist really shifted my mind from this. Essentially, I had this binary where I had this good part of my identity clashing with this bad part and trying to suppress it, and it coming out in ways I didn't like.
Mm.
And the shift in my mindset when she broke all that apart and basically said, all of these parts, part of whatever you're calling the good part of whatever you're calling the bad part, let's look at them. Let's look at why are they doing what they're doing and what purpose is that serving. And it took away the moral judgment of it. It
Mm.
said, no, 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 these parts have needs and they're seeking to fulfill them in whatever way they can. And by doing that, I was able to look at my mind and my way of acting in a totally different way. That was really helpful because it took so much shame away from it purely being like, I am bad, I am a bad person, to
Mm.
being, I have different parts that have different needs. How do I balance that?
Mm.
Um, and it doesn't have to be through therapy to get to that sort of thing. Like I think even in a workplace setting, having really effective supervision has been something I've found really helpful as well. And I think psychiatry is lucky in the sense that it's booked in to our training program. It's a mandated 1 or 2 hours per week. Um, and this is why I think supervisors hold such an important role because they can make or break people. They can really support people to feel like they're really building their skills and becoming not just better doctors or better specialists or whatever it is, but to becoming better people in a way. And it's like, I know that's not the primary role, the primary intention of the role, but it does have that effect. Helping someone move from a nervous, shy junior doctor into a more confident, more settled and stable in the sense of knowing who they are doctor throughout the training. I think that's a really important role. And we have mentors as well that are non-clinical, and I think they serve a similar purpose, maybe a better purpose in that sense.
Lots of doctors have asked me why don't doctors have supervision like psychologists do, and I think it's a great question. I haven't heard it distilled so beautifully in terms of the training program. I'm having a little fantasy just right now of imagining
Mm.
every training doctor that has supervision with a skilled supervisor once a month throughout their training. When it comes to leadership, I truly believe I'm not the only one that the foundation is self-awareness. And
Yep.
so, I think the foundation of being able to connect with other people and help them move towards some developmental thing, whether that's the cause or the project or themselves, we need to have gone there ourselves first. It's sort of leaping out as me as, oh, so obvious, Kieran. Thank you for distilling it as you have.
And I think the important point there is self-awareness does not equate to doing it yourself.
Mm,
They're not the same thing.
no.
You can be helped into that, but you need to seek that help yourself.
Yeah, totally. And for listeners who don't understand the parts theory that Kieran's talking about, this is internal family systems is the name of the type of therapy and the theory. Richard Swartz is the founder, and he has a very easy book, I think, for lay people as well to look at, which is called No
Mm.
Bad Parts. So we'll put all of that in the show notes, and if people are interested to learn some more about that, that's readily available and accessible.
It's a
Um,
great book.
it is a really useful book, I think. I wonder if we might go into this question of suffering and awareness and stigma, Kieran, because I know that you've talked a lot about the stigma of mental illness and mental ill health for, I think, in general. When we're talking about the health professionals who are providing the care, who are, so-called supposed to know what to do, um, what's that like to be in that role, to have that identity, and also be carrying these questions of stigma because of your own health.
Stigma is a very big topic that I could talk about for hours. it is, if I try and focus my thoughts though, it plays out differently in different settings, and it's dynamic and it's time dependent and person dependent. It depends how tired you are when you wake up the next day.
Mm-hmm.
The one of the, you talk about those points where your thinking just shifts. I realized that stigma is not inherently a bad thing. And I didn't think that for a long time. So stigma's bad, stigma's bad. Okay, just pull the moral judgment away from it for a moment and let's look at what it actually is. Stigma is a combination of a biological and a sociological and a psychological mess at times. And it leads to us feeling certain things through an unconscious bias towards someone. It's like, okay, that sounds like a bad thing. It's like, hang on a minute, it's unconscious. So let's just hang on that for a second. It's like there are reasons beyond your control that that is happening. But what is important is you are able and have a responsibility to recognize that if you let it play out as behavior, you are causing harm. So you may not have control over the stigma. You may not have control over the bias unless you work on that in the background. But in the moment that it happens, you have a choice. And even if you're minimally aware of that choice, you know it's sitting there. It's guiding your behavior. And as a result, I think people reject the idea that they stigmatize. They say, well, stigma is bad, therefore bad people stigmatize. Therefore, if I stigmatize, I'm bad, but I'm not bad, so I don't stigmatize. And it's this logical fallacy that just, it doesn't stand up to any kind of scrutiny. Because you look at it and it's like, well, what if it's not bad? And it's like, well, suddenly I could stigmatize and I recognize that I do. It's that first step of saying you can't do something about anything until you recognize it. If you recognize that you do, let's do something about it. So why? Okay, why is there? I'm scared. I'm scared of the person who's here. I'm scared of what they mean to me. I'm scared of what I might fail with response to them. That's all coming in. And so we come to this point where we act upon that stigma in a way that is sometimes deliberately harmful, but mostly unknowingly harmful. So personally, I know, looking way back in my training, the first time I met a psychotic patient, I was terrified of them. I was so scared. I'd never seen someone so thought disordered and so paranoid, and it was divorced from reality to me. I'd never seen it before, and so I had that fear reaction. And I've thought about that moment for a long time, and I thought, I wonder how much of that was me being scared of them doing something, or is it more me being scared of me becoming that? And the reality is all of us could. We can all fall into depression, psychosis. Anyone can. But we don't like to look at that. And so it's easier when we stigmatize to put people as an other. And that's what we're doing. We're putting people as the other and we're treating them differently as a result. Now, being on the receiving end of that as a patient is awful. It really is, because I think I'm in a unique spot where most of the time the people who are doing it know that I'm a doctor. And so I know that I'm experiencing it differently to how another patient would. Having said that, it still happens. And it plays out in ways that are quite nasty. You get little snide comments, you get preemptive judgments of what you should do, you get threats, you get told if you don't do something, then you're going to be put under the act. But it doesn't just apply to mental health either. We do it in health more broadly. We see people of a different culture and we presume things about them. Or we see people who are non-English speaking and think that's too hard. I can't be bothered getting an interpreter. It plays out into discrimination, and people get worse outcomes as a result. And if we care about the fact that our care should be positive and equitable and lead to good outcomes, the best outcomes we can for people, then acting out that stigma as discrimination gets in the way of that.
I feel like I want to say here, here. Well, we see in the training surveys and so on every year that this is a live issue. This is a very live issue for people of colour, for people with gender other than male, it seems, although I certainly worked with some male doctors who've had these kinds of issues for other reasons as well, so I don't want to other them either. There's a beautiful Buddhist practice that's called Just Like Me, and it's as simple as that, as remembering to yourself that this person is just like me. And when we're working with our groups, we teach that if you have a reaction to that, if you say, no, no, they're not, this, I would never behave this way, it's nothing like me, then there's work to do there.
Mm,
That's your indicator that there's work to do there. And if you say they're just like me and it stimulates compassion, a compassionate response, then you're available now. You can connect and work with the person, whoever they are. So I think that's I just offer that to the listeners as something that we can do because, as you rightly
mm.
say, it's unconscious. We can't see ourselves. We don't know we're doing it a lot of the time. And once we notice it, we can actually intervene and interrupt that, make a conscious choice about how we want to behave. And, as far as I remember, doctors take some kind of oath to be provide care to everybody who comes in
Yeah.
front of them. So this practice of just like me is very helpful. Do you feel like these experiences of stigma kind of stack up? Is there a cumulative? How do you make sure, or how do you, I guess it's partly your supervision, how do you make sure that this doesn't stack up into something like resentment or anger or something unhelpful?
I think it does. I think it does to the point of becoming presumed. And that's the sad part. I think self-stigma is a part of that, but it's almost like a learned helplessness. Like you're resigned to the fact that you're just going to feel that people are just going to do it. And whether that provokes more, I'm not sure. But it it's quite demoralizing. It's quite
Mm,
sad to just think
mm,
I'm just going to be treated differently. And that's happened to me. Like not just in a clinical setting, but in a workplace setting where you're just like, this is only happening because of my mental illness.
mm,
And it's like, well, and it's happening again and again. And it's like, okay, just, I just expect it at this point. It's like, and I don't think most of the time, behaviors that lead to that stacking are inherently malicious. I,
mm,
I think it's people trying to do their best in a system that doesn't tolerate sickness, doesn't tolerate
mm,
time away, doesn't tolerate any of that. But with our patients, I think it's similar. Like the most obvious one within psychiatry is people with borderline personality disorder. That is whatever you say about the validity of the diagnosis, it's a harmful diagnosis because it causes people to be treated differently as soon as those three letters BPD are written on a piece of paper. Is one of the most stigmatized illnesses in medicine and psychiatry. And you're already dealing with people who are traumatized for the
mm,
most part. And that experience of stigma and discrimination and re-traumatization compounds and it makes them clinically worse. They absorb that idea that they deserve to be treated poorly, which is often something they have pre-existingly from their trauma from younger years. And so we're actively causing iatrogenic harm to people through the enactment of that stigmatizing attitude. Um, and I think it occurs across people. It's not, oh, the same person's doing it to me again and again. No, it's actually worse, I think, when you see it repeatedly through a system as a patient and you see that there could be one way of doing it and it's not done to you. And it's like, well, why? Why is everyone treating me differently?
mm,
And the sad presumption for most people is that it's because there's something wrong with them because they're bad. If you bring it back to doctors who are not achieving that goal of wellness immediately, that's the presumption too. When you've got a system that struggles to support you, it doesn't look like that when you're through it. It's not about struggling. It's like, I am being treated differently. I am being harmed in this process.
mm. It's very easy to see the evidence when you're feeling like, is it me? And there's this repeated evidence. You're also touching on that the thing about linear. We talked a bit before about, that life is not linear and
Mm.
medical training is not linear, it goes in all directions, up and around and backwards and forwards and backwards and forwards. And you're touching again on that expectation that if a person, any person, including doctors and nurses and allied health, have an illness, they get better and they come back to work. That's simple, it's easy. But those who have, people who have chronic illnesses, physical chronic illnesses can do this too, where they're at work and then they're not at work, or they need extended
Yeah.
time off, or they need slower returns to work. I wonder if there was one invitation that you wanted to send out into the world from this conversation to all of us in health, about how we might respond to that in a more psychologically flexible way, a more compassionate, curious way. What's the invitation that you would make to people?
I think one of the more helpful ways of looking at it is to reject that binary of well and unwell. It's not helpful. It's not helpful in the sense that it doesn't capture where people are at over time. It doesn't
Mm,
capture people who are somewhere in the middle and getting better or getting worse. And it idealizes a state of wellness that can prove counterproductive and quite dangerous for people. So I think recognizing that people are on a journey of ups and downs. Everyone is. Everyone struggles through things. Um, and not needing them to fit within a certain identity of well or unwell, or fracturing that identity into this is my clinical self and I'm struggling with the rest of my life over here, and
mm,
neither the two shall meet.
mm,
These binaries are harmful, I think, and to get away from those is critical. It goes even further. I mean, I mentioned that fracturing, the idea that we have to aspire to a single identity is inherently problematic because it means that we try to repress parts that we don't like, the bad parts. Those binaries of good and bad, like I was saying before, start to become real sources of tension for people and quite distressing for people.
You've used the word state quite a few times, and I don't know if that's a particular thing because you're a training psychiatrist, but it's evident in the way that you're talking. I wonder if it's useful to just talk about what a state is, because I think maybe that's helpful for people in terms of thinking about this state of flux that we're all in all the time, that
Yeah.
we're dynamic. Can you say a little bit about that to help our thinking?
I think I perceive that as almost like a moment. When you're in a certain state, it's looking at you cross-sectionally in one moment. You have all of these things going on in your life. And today on a Friday at 1 o'clock, this is how you're feeling right now.
Mm,
That may predict to a degree how you're going to be feeling at 5 o'clock or on Saturday, but we don't know.
mm,
And that state is an insight into probability, but it doesn't actually tell us what's going to happen. But we have to work with what we know. And so if
mm,
we know that your state has been deteriorating, the probability is that it's probably going to keep deteriorating. We have a responsibility to intervene and for ourselves as well.
mm,
But it also means that that can improve to a different state, a better state.
mm,
Um, but the fact that it's in flux is okay too. We don't need to sit in a permanent state of wellness. In psychiatry, the bane of my existence is risk assessments. I have a lot of colleagues, a lot of clinicians who are obsessed with doing risk assessments and thinking that, doing one 3 weeks ago and sending that through as a referral is somehow relevant to today. Because things change so much for everyone. That state changes. And we may, as I said, we may be able to predict from it, but we need to look at how we are in the now and how we respond in the now. A lot of anxiety that I see is because of not knowing what's going to happen or not knowing how to control it. And there's that false sense of control of the future state of being like, if I worry about it, somehow I'm in control of it. You're not,
mm.
but it feels like you.
Mm. Yeah, that's the paradox of anxiety, isn't it? I think fatigue is perhaps one that most people can get hold of pretty easily. If we think about our state of energy or our state of
Mm,
fatigue is something that's,
mm,
most people have some experience of that over, say, the course of a week or a month or a year. People can relate to, oh, I was so fatigued, then I can see that my decision making was poor, or I needed to have that day off because I was becoming dangerous in some way or other in my medical decisions. Or is there anything you can reflect on, perhaps around this idea of state and also about fatigue and burnout and
mm.
moral injury, that kind of whole, let's call it a spectrum?
Yeah. I think fatigue's a really good analogy for how one is feeling more broadly because it's not perfect to hang your head on because you can deny it, but you can see it a bit easily, a bit more easily. You feel it, like you feel
Mm,
tired, you have to sleep.
mm,
And so as a reflection of how one is feeling more broadly, it's probably a good tool as a bit of an early warning sign. But I think noticing those sort of things uh, is I think a bit of a responsibility of yourself as a clinician, but also looking for that in your team. I was chatting not long ago to a few colleagues, and I could see they were stuffed. They were so typed. I don't know that they could see that. And I just sort of said, I'm worried about you. I can see that you're working a lot and you seem really tired. And they sort of went, oh, fine. But it at least opened the door to a further discussion. And I think having the willingness to do that and not be scared that the person's not going to engage or going to reject you or any of those things can be a really useful tool.
Thinking about this state of fatigue and what role that might have, or using that as an example to think about our awareness of that in relation to burnout or moral injury.
As I said, it is one of those early warning signs that we can look at. And whilst burnout strictly is not a mental illness as such, it feels like it when you're going through it. And I think it tells us that something's wrong. And that early sign of fatigue is an alert that something's wrong. Once we start to explore, oh, what could it be? Then we start to get into, well, there's all these stresses going on that are leading to me feeling like this, and I can't do anything about it. The part that you can do something about is answering the question, do I need to pause? Do I need to use this fatigue warning sign as license to pause? And that's a hard thing to allow yourself to do. But I think the more we explore this across healthcare, the more we acknowledge that it can be reasonable to jump in at that point and to try and head off, getting to the point you're taking 2 months off because you're so burnt out and sick, then I think they're useful tools.
I want to just touch on the idea of empathy and compassion fatigue before we move to wrap up our conversation. It's a misnomer to talk about compassion fatigue. It's a bugbear of mine that the research has really shown us that it's empathy fatigue, empathic burden, rather than compassion fatigue. So that's my own little soapbox. But I wonder if you might make some comments before we finish, Kieran, about empathy and compassion and the roles that they might play, both in taking better care of doctors systemically and also in being a doctor.
Yeah, I think you mentioned moral injury before, which I didn't touch on, that comes into this. The desire to provide care and empathetic care and compassionate care, I think it's there for most people at baseline. Most people want to do that. But the stuff that gets in the way makes that harder. It makes it so that gets relegated to a secondary consideration. Time is the biggest one. We just don't have time to do it well.
Yes, it is.
And so we feel stressed, we feel exhausted, but our patients feel like they don't care. They've been here for 2 minutes for a ward round that I didn't know what time they were coming for, and it's interpreted in a totally different way to what we see it. That doesn't make it any less valid. That's their experience. They've got this illness that they're experiencing. They have no idea during the day when anyone's coming. They're eating garbage food probably, and being poked and prodded by nurses all day. And then to have the person who's making decisions about their care come and spend 2 minutes with them because they have to and because they have no more time to, everybody suffers in that dynamic. And the doctor suffers because of that moral injury. And it's like, well, what do you mean by that? It's we know what we want to do to affect good care. I know, for example, that discharging someone to a supported environment, even if they have to have ongoing treatment, is going to be much more likely to continue their hopeful state of wellness that we've gotten close to in the inpatient unit. The number of times where I've had to discharge people to a car or to the street, knowing how dangerous that is and knowing that they are not going to stay well if I do that, but there being no other choice. That hits home. That hits hard. It's like I am choosing for this person to experience that because there's no other option, or there feels like I can't access any other option anyway. And I think what one of the reactions to that is to shut off and to become numb about it, and that comes through to patients. There's this detached, oh, we're just doing this, and I think the danger too is when we are truly empathetic, we actually move from being an authority to an advocate, and we shift a little bit to being able to support patients with providing them the expert opinion, the expert advice that we have to make a decision that's best for them. And we struggle with that because we struggle to connect with the fact that that might be different to what we think is the right decision. And if we're being truly empathetic, we need to connect with why. Why do they want that? What is the value to them of engaging with a decision that is different to what is medically recommended? And it disconnects us from being able to be compassionate because we feel like they're being bad or they're making a bad decision. And the danger too is you'll often see that's where coercive treatment comes in, where, and not just in psychiatry, I mean like on the medical wards, where no one questions someone's capacity until they disagree. And as soon as that happens, that's when the capacity question comes up. And it's like, well, that's not truly being compassionate or empathetic. That's, bringing out a legislative tool when they don't agree with you.
It's in some ways managing time.
Yeah, exactly.
Or managing other resources.
I think part of it comes from a true desire to do what is best for the patient, and sometimes that crosses over into telling the patient that they're doing the wrong thing or forcing them to do something they don't want to do.
We could talk all day, I suspect. I just want to touch on one thing that's in your bio, this beautiful expression of how can we create cultures where vulnerability is valued? I wonder if you'll speak to that, about this phrase of valuing vulnerability. It seems a very powerful idea to me.
I think it is because it shifts our current goal from supporting people who are experiencing difficulties or experiencing struggles within the workplace to not just how do we get them back to where they were and get them back to functioning doctors, functioning healthcare professionals, but taking an approach that has been used by the lived experience movement and in mental health and saying, what I have gone through is valuable in and of itself. From their point of view, I don't need to be a clinician for this to have value. I think appropriating that is quite useful because it's not the same, obviously. As I said before, me being a doctor patient in a medical environment is not the same as being a patient. But it comes with unique insights that someone who has not been through that won't understand until that is shared. And I think, how do you do that? I've reflected on that for a long time. I think you have to be able to use tools that allow people to connect with that. I think, well, you can't just say, oh, this person, they've gone through this and look at them now, they're doing so well. That's not real. I mean, sure, that's the point they're at now, but that's not the journey they've been through. And so I think it's much more about sharing the stories of people who have experienced real distress and the impact of how the system reacted to that that's most beneficial. And I think of three people who have done that really well. And the first really kicked off my interest in this, and that was Jeff Toogood. So he was the founder of Crazy Socks for Docs. So watching his speech about his experience of suicidality was profound. It was life-changing for me hearing that, because it was so raw. He was in excruciating detail. I felt every moment of that speech. And the same thing applied when I read Steve Robson's piece, who was the former AMA president. He wrote about his very close suicide attempt on the ward, and was stopped by some of his colleagues who knew that he was not in a good place. That was about 35 years ago now. But he didn't tell that story for a long time because he felt like he couldn't. But when he did, it hit home so hard for people because it was just, again, a moment in time that he was in complete distress and felt in despair and couldn't find a way out of it. And it was just so powerful. But then even in a more medical sense, been listening recently to a audiobook from a doctor who formerly had bowel cancer before he got into medical school. So it's Dr. Ben Bravery. He, who I think you did a panel with some time ago.
I think
He,
Ben's coming out to Uluru with us for our
oh, fantastic.
private medicine. Yeah.
Yeah. I think listening to this as an audiobook really had a powerful effect beyond just reading it, because I felt so connected to his journey through treatment, through medical school. It was that rang true for me so much. But his experience through treatment in particular just hit on so many points that patients value and experience and are not done well, that it just, for a doctor to be talking about those experiences, and for me having experienced some of them myself, like that is so validating. And it's more than just validating to me, it's valuable to understanding how we engage with patients more broadly. And that's where the value is. It's not just, oh, hearing the story makes me feel good. It's no, what do I learn from this? And if I'm learning that, I gave the experience of the ward round, things like that, and actually doing something about it, that's where the value comes from. That's where we're actually able to use these stories, use these experiences for positivity and for improving healthcare. And that's exactly why I think being able to blend one's clinical experience with what we have experienced in our lives, that doesn't necessarily even have to be ill health, but that's the example I've got, can be powerful for how we engage with patients and make healthcare a better experience.
Mm. Well, I think you're certainly in that list, Kieran. I mean, when I first learned of you, I think that was through the Gathering of Kindness, probably 6, 7 years ago,
Probably.
sharing your story. I think that, these stories are powerful. That's what we resonate with. That's how we understand our own experience and other people's experience. I think there's some research to say that people who read more fiction books have more empathy, because they're, learning about characters and how people
Yeah.
respond to things and to each other. So, I'm just deeply grateful to you and to the other three people that you've talked about. I've been lucky to learn about all of their stories too. And again, we'll put all of that in the show notes. I think maybe it's a good place to kind of come to our finishing, where I think you used a lovely phrase when we were preparing for our conversation today, talking about that we don't want doctors to be some sort of beige version of humans. I love that expression, that we don't want our doctors to be this kind of beige. I mean, let's work with the robots if that's what we want. And we know that we don't really want to work with the robots. We want to work with human beings. And so, you've done a just incredibly beautiful, generous job today of showing us a lot more of your humanness and your whole story. And I think that shifts not just other doctors and other healthcare professionals' impression of who they can be and what their identity or self might be in relation to their work or including their work, but it also can help the general population think about, who's this person that I'm meeting. I think lots of doctors have experience of aggressive patients, not because of mental illness or any other thing, just because of Dr. Google or, this sort of I've got more rights kind of way that we are in the world now. I think it serves us all well to have a more grounded idea about 2 people, 3 people, 10 people meeting together in a room to have a conversation about a shared purpose or a shared outcome. I think we all can benefit from that. Do you have something that you say to yourself that helps you keep going when things are tricky as they are? What are the things that you can say to yourself to help you keep going? Not so much to push through, but to keep going in useful, kind, self-sustaining ways.
I think what I learned when I was really, and multiple times in the depths of suicidality, was the thought that this will pass. It's a time thing. That will be okay. And
Mm,
it's not saying it fixes it, but it gives me space to press pause and let
mm,
things just be okay for a moment.
mm,
When you're in that bad a space where you want to act on it, time can be critical.
mm. Yeah. Well, I kind of wish that this moment wouldn't pass. I've really enjoyed talking to you this morning, and I really appreciate the open sharing and the really thoughtful. You've been on this journey of thinking about how health works for everybody for a long time, and I really appreciate you sharing your wisdom today. So thank you for being here with us.
Well, I really appreciate the opportunity. I hope people get some value from it.